Welcome to this clinical case study explainer. Imagine you're evaluating a pediatric patient who just presented in your clinic. They've got this fiery, intensely painful sore throat and a really distinct, rough, sandpaper-like rash. The kid is miserable, the parents are stressed out, and it's totally up to you to quickly identify the culprit. Well, today we are putting a massive bacterial suspect right under the microscope. We're talking about Streptococcus pyogenes, commonly known as Group A Strep. We're going to treat this exact scenario like a clinical grand rounds, breaking down exactly what you, as future physicians, absolutely need to know to recognize, diagnose, and neutralize this pathogen.
Okay, let's lay out our roadmap for this case. We'll be hitting the clinical presentation, diagnostic workup, virulence and toxins, immunologic complications, and finally, treatment.
Section 1. Clinical presentation. Recognizing the pyogenic threat.
When you're assessing a patient for streptococcal pharyngitis, the classic strep throat, you are looking for a very specific constellation of high-yield clinical symptoms. You're going to see fever, the sudden onset of a brutal sore throat, and those enlarged, tender cervical lymph nodes. But honestly, here is a major diagnostic clue for your clinical reasoning. Look for the lack of a cough or a runny nose. Viral pharyngitis almost always presents with those classic upper respiratory symptoms, but a true Group A strep infection typically doesn't. That absence is basically a massive red flag pointing you straight toward a bacterial etiology.
Now, beyond the pharynx, this organism is notorious for localized skin infections too. I actually highly recommend using visual mnemonics to anchor your memory here. Think of the pyogenic pygene. It's a great mental hook for the pyogenic or pus-producing nature of this bacteria. Strep pyogenes frequently causes highly contagious skin conditions like impetigo, which you'll see a lot in young children, as well as cellulitis. Cellulitis is that diffuse, spreading inflammation of the skin and underlying tissue that happens when the bacteria sneaks in through a break in the skin barrier. And then we have the specific toxigenic effects. When Strep pyogenes releases what's called the erythrogenic toxin, the whole clinical picture escalates into scarlet fever. As you study for your boards, you absolutely must lock in these buzzwords. You're looking for the bright red, bumpy strawberry tongue and that classic rough sandpaper rash. Interestingly, that rash usually spares the area right around the mouth, which we call circumoral pallor. Oh, and as the acute phase resolves, you'll also commonly see desquamation, which is just the peeling of the skin.
Section 2. Diagnostic workup, proving the pathogen in the lab.
So what is our next move to actually prove this is definitively Group A strep? The crucial point is following a very specific laboratory algorithm, step by step, to separate S. pyogenes from a literal sea of other organisms. First up, you plate your swab on sheep blood agar. You are looking for beta hemolysis, which is the complete, clear halo around the colonies where the red blood cells are destroyed. Next, you apply a 0.1 unit bacitracin disc directly to the agar. Group A strep is distinctively sensitive to bacitracin, meaning its growth gets totally halted. Finally, you run a PYR test, which will give you a positive result. That specific combination of being beta hemolytic, bacitracin sensitive, and PYR positive is your definitive laboratory confirmation. This map brilliantly illustrates exactly where our suspect sits in the grand scheme of bacteriology. If you look at Brown's classification based on hemolytic patterns, you can see the initial branching. We move right down the beta hemolytic, or clear, pathway. Then we differentiate using the bacitracin disc we just talked about. Group A, Streptococcus pyogenes, is sensitive, which cleanly and clearly separates it from the bacitracin-resistant Group B strep. It is just a beautifully logical diagnostic tree.
Section 3. Virulence and toxins, the microbial arsenal.
Let's move to the microscopic level, because if there is one single structural component you must remember, it's the M protein. These are these tiny, hair-like projections extending right out of the streptococcal cell wall. The M protein is literally the major virulence factor of this pathogen. It acts like an invisible force field, actively inhibiting the activation of the alternate complement pathway and totally resisting phagocytosis by our white blood cells. To put it simply, without the M protein, the bacteria just isn't virulent. It is the absolute key to its survival inside the host. Let's contrast two key enzymes to see how this builds our understanding of the bacteria's destructive capabilities. We are looking at streptolysin O and streptolysin S. Now, both of these destroy red blood cells, but they go about it very differently.
Streptolysin S is oxygen stable and causes that classic beta hemolysis we see sitting right on the surface of our aerobic blood agar plates. It is not antigenic. But what's absolutely crucial here is the profile of streptolysin O. It is oxygen labile, so it only causes hemolysis in deep anaerobic colonies. More importantly, streptolysin O is highly toxic to both leukocytes and the heart, and it is strongly antigenic. As you'll see in just a moment, that antigenicity is a huge clinical clue for us. Section 4. Immunologic complications. The high stakes of untreated infection. And now we reach the absolute climax of our grand rounds. What happens if this patient goes untreated? Well, it can trigger devastating post-infectious sequelae through two totally divergent pathophysiological mechanisms. First, acute rheumatic fever. This happens when the patient's own immune system creates antibodies against that virulent M protein we discussed earlier. The tragic part is, those antibodies can actually cross-react with normal autoantigens in the patient's own heart and joints. On the other hand, we have acute glomerulonephritis. This is a completely different mechanism. It's a type 3 hypersensitivity reaction, where circulating immune complexes of antigens and antibodies literally get physically wedged and deposited into the delicate glomerular basement membrane of the kidneys. Let's zoom in on rheumatic fever, which typically follows an untreated throat infection. The clinical presentation here is severe. Patients might develop migratory polyarthritis, which is this joint pain that literally jumps from one joint to another. You might also find painless subcutaneous nodules under the skin or a very distinctive rash called erythema marginatum. Neurologically, it can cause rapid, involuntary movements we call Sydenham's chorea. But the absolute worst part, the main reason we are so terrified of rheumatic fever, is the permanent damage it does to the heart muscle and valves. It often presents as endocarditis with these destructive vegetations along the valve closure lines. Now, acute glomerulonephritis can actually follow either a throat or a skin infection. The timeline here is a massive diagnostic clue. It usually develops about 10 days after pharyngitis or about 3 weeks after a skin infection like impetigo. Because those immune complexes are actively damaging the kidney's filtration system, the patient is going to present with dark-colored urine, serious swelling or edema from fluid retention, and newly elevated high blood pressure. So think about this. When a patient presents with these severe immunologic symptoms weeks after they were actually sick, the original bacteria is usually long gone. You can't just swab their throat anymore. It's useless. This is exactly where our knowledge of streptolysin O comes in to save the day. We measure the anti-streptolysin O, or ASO titer, in the patient's blood. An ASO titer of 200 or more proves definitively that the patient's immune system recently fought off a Group A strep infection. It is the absolute vital missing puzzle piece that lets you confidently diagnose these post-infectious immunologic complications. Section 5. Treatment. Neutralizing the threat. Let's transition to how we resolve this case. I want you to consider this historical context for a second. This disease was extremely feared before widespread availability of antibiotics. Honestly, it is so easy to take for granted today, but illnesses like scarlet fever and rheumatic fever literally used to be leading causes of death and permanent disability in young people. The historical weight of this pathogen is just immense, and it really underscores why prompt intervention is absolutely non-negotiable. The primary goal when your patient presents with that fiery throat and the lack of a cough is to stop the whole bacterial cascade dead in its tracks. Prompt antibiotic treatment of streptococcal infections, usually with common penicillins or amoxicillin, doesn't just make their throat feel better a little faster. It actively eradicates the pathogen before the immune system even has time to generate those dangerous cross-reactive M protein antibodies or form those kidney-destroying immune complexes. By writing a simple prescription, you're literally saving their heart valves and their glomeruli. We have covered a lot today. The bedside presentation, the lab confirmation with bacitracin and PYR, the virulence factors, the immunologic fallout, and the life-saving treatment of Group A strep. So I want to leave you with one final thought. When that next pediatric patient walks into your clinic with a sudden fever and a red throat, how will you apply this diagnostic vigilance to protect their future heart and kidneys from what might initially seem like just a simple sore throat? Keep your index of suspicion incredibly high, trust your lab algorithms, and intervene promptly. Thanks for joining me on this explainer. Keep learning, and I'll catch you on the next one.